Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
We're really excited to bring you talks that we recorded as part of the CANUCS Surgical Fellows course. CANUCS is a national organization that stands for Canadian Collaborative on Urgent Care Surgery, and they've been doing some amazing work in understanding emergency general surgery and trauma in Canada. Dr. Chad Ball and Dr. Kelly Vogt were instrumental in bringing together some really fantastic speakers back in April of 2024 to talk about the critical knowledge and skills that surround obtaining a staff job, as well as being successful both personally and professionally in a demanding career. This was a really fabulous course aimed at surgical fellows. Dr. Rob Leeper is an acute care and trauma surgeon at Western University in London, Ontario. In this talk, Dr. Leeper talks about things that he wished he had known when starting out in practice. And he gives some really profound advice about how to think about one's surgical career. He also gives some amazingly practical points, like having a couch in your office, and also the famous "give me a Cordis" or "give me death." You can check out the previous episode that we've done with Dr. Leeper with the links in the show notes.
My talk here, the opening slide, has an album cover from the song by Faces, Ooh La La, which the main refrain is, "I wish that I knew what I know now when I was younger." And you'll see this is kind of an updated talk. Probably one of my favorite talks I ever gave many years ago now at the Canadian Surgery Forum. It's almost 10 years on into practice, and I'm looking back at what I said and what I thought in my first year out. And it's amazing, very little has changed. I've added to the content, but it all still rings true, maybe just for me and hopefully for everyone, with a little more resonance and a little more emphasis in certain areas. So again, this is an email from many years ago that I still have from Dr. Ball when he said, "Hey, I'm doing this session at CSF and I have an idea for some great talks, Dr. Daw, Dr. Engels, Dr. Macbeth." And he said, "Rob, why don't you come and talk a bit about, starting out, your first year in practice." And he said that in the email, I have a dream team in my mind to assemble. And again, I was talking to Amir about this, a lot of my stuff's going to fall apart if it's a podcast because the visual matters a lot. But, the dream team, first dream team was this team that played in the Barcelona Olympics in 1992. They played basketball for America. And they had amazing players, among them like legends like Michael Jordan and Scottie Pippen. But they also had this one rookie, a kid named Christian Laettner, that no one liked, and Jordan would make fun of, and try to beat ping pong in their residence. But I sort of felt like, as the rookie in the team, it was sort of like Murad and Chad asking me to come and give this talk, which was fun. And so I still feel that way, even though it's 10 years later. I still for sure feel like Christian Laettner trying to give this talk, which is fun. So that was the talk back in the day. So here I am, 10 years on, and still, just like yesterday, we talked all about stopping hemorrhage. What was my first slide 10 years ago? It was all about hemostatic adjuncts, right? That you need to know these so well, because whether you're doing elective surgery or in this case, trauma surgery, a liver injury, a terrible amputation and pelvic fracture, where it's a Medtronic-sponsored meeting at an Alpha Medicine screen. Like, we're talking about techniques, adjuncts to stop hemorrhage. That's still, back then and today, is the number one mantra of a trauma surgeon. We are hemorrhage control surgeons, and having all those techniques in your mind is so, so important. Hemostatic adjuncts. And I did add today, I thought, the one thing I didn't have on the screen then, and I may be on the wrong side of history because there's lots of debate about this and the evidence from like the UCARE-BOA trial we reviewed at our journal club recently. I still find, and Dr. Perry was here yesterday, I still know a few patients who I am convinced we never got back, who are long-term survivors if it wasn't for aortic occlusion. So I'm still a believer in the select role of aortic occlusion balloons. So I have that in my talk today, just to maybe a little controversial and a little bit honest, because I'm nothing up here about anything but honest. And I still go to that device in select times for sure. There's two fellows from Queens and Vancouver. You're not yet in a spot to be hiring a secretary, but you will very soon. And I can't tell you how important it's going to be. It's really important. If you can find one who's experienced, I actually hired Neil Perry's retiring secretary. I can stay on for an extra year and train mine to take over the job. This is Gurinder. She's my secretary now. I've had her now for 10 years. She's fantastic. And that will make or break you. I promise you. I have no further advice on how to get a good one, but it's just that it's really important. So focus on that for sure. This is a sort of minor point, but a really good headlight matters. I don't know what everyone's shop is like in the world. At our hospital, they have these sort of a fleet of generally crappy ones that are plugged into the wall or the machine. You can't move around with them. Having your own makes a big difference. It's a freedom kind of thing when you walk into somebody else's operating room and you pop your headlight on. It's like suddenly it is like a spotlight comes into the area of bleeding. You're like this, like, it's a big deal. It's a silly little thing. It's a minor point, but when you're at the next big American college meeting and you're walking around the exhibit hall, find a good headlight, buy one. You will not regret it. As an acute care surgeon, the way you work and the way you get paid can be different, right? How much call am I going to do? What do I get paid for each week of call on the acute care service or the trauma service? And there can be a tendency to try to find other avenues of work. Maybe I should take some scope time at a small hospital. Maybe I should do whatever. I promise you, and anyone may listen to the recording, is that you're always way busier than you think. It's okay. I fill my boots with clinical work, but it's stuff that empowers me, that I enjoy doing, like acute care weeks and trauma weeks. I don't, do other things that are maybe remunerative, but not fulfilling or enjoyable. Your week is too short. Your year is too full for that stuff. You'll do just fine, getting paid for and working on the things you love. So that's my advice there. In the same vein, try not to volunteer yourself out of a promotion. So this is just some slides of, giving talks at CSF, teaching in the medical school, running an ultrasound course, the ones on the other side of the screen are a course I teach at high school. I go back to my old school and volunteer a day out of the year to teach the high school kids. It's my son intubating a mannequin in grade 9 there, which is all fun. And I enjoy them. So I only say yes, I guess, to academic asks that align with what I want to do, that empower me, and that end up getting me promoted. Because, at the end of the day, that's my promotion letter. I got promoted last year. At the end of the day, they do want to see that you're doing things academically and outside the operating room, obviously. But again, say yes to the things that empower you and that fit your mission for promotion. It's okay to say no to things that don't. This is unchanged from previous years, and the next couple slides all fit together. I made this slide, I forget why, years ago, and it's, again, for the audio format, it's a picture of Continental Army and sort of Washington saying, "Give me freedom or give me death," but I replaced freedom with the word Cordis, which is, again, a brand name for a large volume introducer sheath used for doing blood resusc trauma. I really think that's important to be able to get intravenous lines and use IOs and things, but there's something really special and powerful about a Cordis. And so I just remind in a hemorrhage course follow-up, whenever you are looking after a patient with massive bleeding, get a Cordis or they will not make it. In the same line, I would say that when you're looking at skill sets, as a trauma acute care surgeon, somebody working in resuscitative medicine, I think it's probably fair for me to say now, and I agree still, that critical care skills, like being able to get a good central access point, being able to do a slick and easy, surgical airway and high quality point of care imaging, probably matters a little more than being able to put in the world's best stitch in, the aorta. And I'm going to go back. The next slide is meant to say that in the same way that I think critical care skills are a little more important than path operating skills, I also think that crisis management skills are a little more important than those amazing operative skills. If you're sort of counting on yourself to be able to be Michael DeBakey in order to save a patient, to be the world's greatest surgeon, again, we're all average surgeons. And at the end of the day, if you can make the right decisions about when or when not to go to the operating room, if you can arrange the right environment and people and stuff, the actual operations become easy. If you set it up well and you can manage the crisis and see with situational awareness what's going to happen next before it happens, then the actual bites, the stitches, the clips, the ties, that part takes care of itself. So I really do think crisis management skills and communication skills matter more and don't get enough credit, I guess, as compared to the sort of the more technical operative skills we like to pontificate on. Yeah, that's a video of me putting in a tampon balloon across a liver gunshot wound, which is dead easy to do. It does not require, like massive quantities of skill. You're just putting a clamp through the liver and pulling a balloon through, right? But it's about getting there, about saying, like, I remember this patient goes, oh, should we go to angio with him? Maybe it's embolizable. Like, no. Let's go to the OR. We'll make a big cut and fix this guy up. So anyway, I think it's important to have great mentors. No, that's not true. I know it's important to have great mentors. And I can't really update the slide. They're older pictures, but people who are your fellowship directors right now, like Elliot, how it was for me in Baltimore, having amazing partners from practice and in mentorship like Neil Perry, Dave Efron, and Bill Wall, man, that really matters. Again, it's kind of one of those things, either have them or you don't. But if you have them, like, hang on to them with hoops of steel. They are such an important and valuable part of your training and your life, and stay in touch. I still see Dave all the time at meetings. I still talk to Elliot over texting and over social media all the time. It's like, it's really, really an important thing to keep up to. And come to meetings like this because it gives you a chance to be in touch and stay in touch with people in your life. What's next? Yes. If you having great mentors is awesome. Having great partners is the continuation of that. And that becomes a choice about figuring out where you're going to work. You want to choose a job that has the right opportunities for you, the right resources, that pays you well. But man, picking an awesome group of partners matters quite a bit. Dr. Vogt, Dr. Perry, who are all here, it's a really big deal. And so that, I would say, look around carefully. I was just talking to Amir about his group in Kingston. Like, it really is a big deal to figure out who you're going to like working with, because that's what's going to determine a lot of your happiness day to day as well. Ooh, okay. This is cheesy. If you talk about like the number one like rules of giving talks, they're always like, don't put too much information in the slide. And whatever you do, don't show like vacation photos of you and your family. They're all on here now. Tough luck. Because the point, and I'll try to make a semblance of a point to it. And here's what it is. We all work really hard. We get paid pretty well for the work we do. When you go away, you need to, last night we were talking to Scott about, Scott Kimura, about spending a year in Bali after fellowship and just turning it off. Just saying, I need to click out and off of this for a minute and get away. A year is a long time. It doesn't have to be a year. A week or two at a time makes sense. Like 3 weeks in, it's 2 or 3 weeks, Kelly, you're still away for. 2 weeks in Florida. These are the way to do it. So when you go away, you owe it to yourself to go with your whole family away somewhere amazing. To go take them to Disney every damn year, right? When your best buddies from residency get married, go to the wedding. Even if it's far away, and bring your kids, okay? Your best pals from fellowship who you get to know, who maybe still work in Europe, plan trips and get together with them. You'll never regret it. It matters so much. If you go to meetings, we're just in downtown Toronto, not exactly the most exotic place, but meetings that surgeons go to are often Hawaii. Bring your kids, go to surfing. If they're in San Diego, book golf. If it's Chicago, go on Matt Kaminsky's boat and have a great time. And the point is, wherever you go, Australia, bring your family. You have to go anyway. So make it count double. Make a vacation of it and really go to these meetings, but get away. Bring your kids, bring your family. I cannot preach this enough. If there's a place to spend money, it's on trips and memories, because those ones they can't take away from you, no matter what happens. So it's interesting. I was finishing in my fellowship and I talked to Dave Efron. I said, Dave, any advice for the first year of practice? Like, should I be thoughtful and cautious about doing tough cases? Maybe kind of like put them off later, or try to kind of have a quiet first year. And he got actually a bit mad with me. And he said, Raul, I didn't train you to go home and duck tough cases. He says, ducking a tough case, everyone will know, especially you. So even if it's your first day on the job and there's sort of good, mojo about the first day back or your first day of work cases, they're going to be hard, but do not put them off. Do not chicken out. Do not avoid that work. Take it on head on, because, I think for a million reasons, avoiding a tough case and saying it's outside maybe my scope or my comfort level, you'll never get it back. And all of a sudden you'll have a very narrow scope and a very narrow practice, and it's not going to be what you, again, were trained by your awesome mentors to do. As an acute care and trauma surgeon, it's important to stay really ready to go up in the chest. Okay, it's again, most of our elective practices in the abdomen, but being able to do that means you're gonna meet patients who need that from you. So, like, don't lose that. Speaking of scope, at the same time, if you were here yesterday, it's really important to be ready and able to work in the neck too. These are two areas where I think, our colleagues who have general surgery-based training just go, "Whoa, hold on, that's somebody else's backyard." No, it's still yours. And it has to be, or you're not doing your patients or your career any favors. A slide that I is new this year, and it probably might be the most important slide of my talk, and I'm going to spend a minute trying to explain it. So the title says, "Honestly, more than anything, be kind." And I have pictures of it's an Atul Gawande post from the New Yorker about coaching doctors. It's a picture of me and my son coaching him in football. And it's a picture of J.K. Simmons with the phrase, "Not quite my tempo," from the film Whiplash. These are all different ways to think about instruction and about how to function in high stakes systems, right? Surgical, athletic, musical. I think there's a part of me 10 years ago that thought that if I got more mature, more senior, had more gravitas, I should become more like J.K. Simmons. Has anyone here seen the movie Whiplash or not seen it? He's a very exacting, very demanding figure in that movie, to his chagrin and to the dismay and harm of his trainees, okay? I can't remember for sure, but if I thought that back then, I was wrong, and not a little wrong, loud wrong, dead wrong. Not only is it, not the right thing for the world we live in today, but it's the absolute wrong thing for you as a trainer. It'll cost you personally, it'll cost you the trust of your residents, it'll cost you, in some ways, your whole career if you get on that wrong pathway. Kindness actually matters a ton nowadays, and it might not be it might not be the way to make absolutely top performing surgeons, but at the end of the day, you have to make sacrifices. And I actually truly believe that kindness in how we train one another and how we treat one another matters more than anything else. And that's a change for me, I think, that's come to me and been more clear over the last 10 years. Speaking of kindness, there's also a phrase I like, gratefulness, thankfulness, okay? I've saved every thank you card I've ever gotten from a patient. I put them on a bulletin board, I'm like, it's full, I take them off and put them in a folder and sort again. This is a mirror. It's hard to picture it. It's a cool metal mirror with these handmade, hand-wrought leaves made by a patient's father for me that I got just this a few months ago. And it's the coolest thing. I can't tell you, the sacrifices you make from your family time, for your life. We trained till we're 33 years old or whatever. It matters a lot. And those cards and those little notes of thanks for fixing people's hernias, whatever little things, they matter a lot. Hang on to them. They're a good thing to look back on. And in fact, the bulletin board in my office is behind my computer screen. So I'm getting shitty emails, pardon my French. I kind of go, but I look behind the computer and there's all these reasons of hey, this is why we do it. Again, simple advice. Have a couch in your office. That was a picture I had 10 years ago. That's my actual couch, which hosts rounds most mornings, birthday parties for our trainees. It was Zayd's birthday and on Access. And maybe my kids will come in and hang out there if they're at work with me that day and I can't, there's no babysitter. It's a multi-useful tool. And of course, crashing between cases matters a lot because you're a little bit more fresh for that next case and that next, on-call all-night kind of scenario. This is my slide that remains unchanged. I said, don't be good at ultrasound, be an absolute wizard at ultrasound. I think that as an acute care and trauma surgeon, it's going to continue to matter quite a lot for you. This picture of me doing a TEE, which was sort of a part of my practice, gotten bigger and bigger over the years, especially as we're doing more ECMO or ICU. These skills really matter, and don't lose them. If you stop put the probe down and let your trainees do it and stop looking and thinking and being critical, that skill goes away and it's going to be an important one for your whole practice. So hang on to it. Say yes to bone on wall. And again, Neil and I do a lot of horrible bone on wall stuff in London. And I think my partners must kind of laugh and go, those morons. Send them why are they doing that? That stuff terrible, doesn't pay very well. It's very difficult, lots of difficult outcomes. There's a lot to be said for it. You're going to meet a lot of patients who have had trauma laparotomies, like this young man here, with a skin graft on a eviscerated abdomen with a colostomy up. You can see the clamshell thoracotomy, one of my favorites. And if you can take this person and go from massive component separations, biologic mesh, onlay with plastic mesh, hybrid vac therapy to a closed abdominal wall, it's a really big deal to the patient, to you, and to your partners. You're doing a big service to your community, and you'll be someone who your partners look to and say, we're glad they're around, not just to look after the injured patients and do the acute care stuff, but because they can help us kind of come bail us out of bad abdominal wall problems. So there's a million reasons why you should still say yes to abdominal wall. Last 2 slides. They work together. Sometimes you're going to lose a patient and it's going to really, really hurt. This is an example of one patient that I had where, tragic, motor vehicle collision, ED thoracotomy, big save, really brought this guy back from the dead, thought we had a durable outcome. And then it's one of those stories where 99 out of 100 things went right, but the one that went wrong was a blown cuff, a failed airway exchange in the ICU that I was in a meeting for, and I came out and went, oh man. That there's a Donald Glover meme where we go to the apartment door and it's all on fire, he's pulling pieces. That was me, he's in arrest again? It's 5 days later, and now because he aspirated and lost his airway. And I thought, and I still I think of this all the time. I can picture this guy's kid at his bedside. I'm like, that hurts. Just to compare it, a patient that I had who, same sort of idea, terrible motor vehicle collision, came in an arrest, ultrasound probe showed an effusion, a pericardial effusion, opened her chest, get her back in a big hurry, fix the hole in the heart, take her to the OR. She has catastrophic brain injury and she ends up dying. But the family was so thankful. They gave me a thank you card, right? And that one, I still feel badly for her. I still hate that outcome, but I don't have the same regrets, the same bad feelings. And I think the difference is we did everything right here. We did everything the right way, made the right choices, and didn't make any, there's nothing that I can look back on and say, oh, that was my error. Whereas here, if I just not been in that meeting and been at the bedside when my fellow did the airway exchange, I think this guy's still alive today. And so I say these 2 things to you to say, you're going to have patients die for sure, have bad outcomes for sure. But as long as you've been present, made the right choices for the right reasons, if it happens to be a bad outcome, that's going to be okay. And all more reason not to take shortcuts, make choices for expedience or ease or, dumping off on your partner. Those kinds of behaviors will leave you with regrets the rest of your life. So if you can avoid those, it'll pay dividends for sure. Okay. Oh, and finally, of course, my sign off was because I emailed Chad and Brad back and said, okay, so what do you think? Anything you would say, any advice you would give to young people starting out in trauma surgery? And they said, oh, yeah, that's really easy. Just whatever you do, just don't up. That was their final advice. So anyway, so thank you very much. Appreciate it.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.